Dr. Merav is a man of many talents, many interests. We were privileged to have him here. And he has, of course, been involved in lung cancer a great deal, and he sees patients, most of whom have been cigarette smokers. So instead of just telling the patient, go quit smoking, which we know is not effective advice, Avi has taken an interest in trying to handle and manage this particular problem and thereby prevent some of his cases of lung cancer. So Avi has done research in this area, and I'm very happy to introduce him for this unusual topic. Thanks, Avi.
Thank you, Arthur. So, Arthur's right. You know, I've been taking care of people who were smokers who were paying the price and never even really thought of the smoking per se as the problem. I would make it very clear to somebody who needed a bypass operation that unless they committed themselves to stopping, I wouldn't operate on them, because the risk of vein grafts closing is increased tremendously by ongoing cigarette smoking, et cetera, et cetera, et cetera. So it wasn't until really recently that somehow I developed this interest in this whole issue of smoking. And the more I dug into it, the more I realized what an unbelievable epidemic it is that we are living with. And because we have been living it with, most of us sort of almost accept it. You know, it's like you live in California, you know you're going to have an earthquake. You live in North America, you're going to deal with consequences of smoking. But as I dug into it, more and more of the information came out, and I really want to share this with you to increase the awareness of the issue of tobacco smoking, and then at the end really come back home and see what it is that I think we need to do to our patients, to our surrounding community, to our colleagues that we work with here at Phelps. How serious is this epidemic that I'm talking about? A lot of numbers here this morning. I'll try and give you some time to let them sink in. So almost 500,000 premature deaths. Now, I'm going to use the word premature or preventable death, because death is still not preventable. It's just when somebody, instead of living their life out to 80 or 90, die at 50 as a consequence of smoking. That's the death I'm talking about, premature death. And there's almost 500,000 of those that are related to smoking, not just lung cancer. I'm not going to be talking just about lung cancer. But that's a staggering number. Now, get your head around this one. Tobacco has killed 10 times more Americans than have died in all of the wars that this nation has been in combined, from the War of Independence on. You take all those casualties, you multiply them by 10, and you come to what tobacco has killed. That's an amazing figure. And all of these were preventable. They were caused by smoking. Anybody want to guess what that number is? 20,830,000. That's the number of people. Look at the bottom line of this table. It's the total number of premature deaths caused by exposure to tobacco, either first-hand smoking or second-hand smoking. This number is from the 2014 report of the Surgeon General. And the biggest number here is really cardiovascular and metabolic diseases. Almost 8 million people. This is for a period of time of 50 years between the first report of the Surgeon General in 1964 and the most recent one in 2014. So over 20 million people died as a consequence of smoking, first-hand or second-hand. And the biggest number is cardiovascular and metabolic diseases. Above it is smoking-related cancers, primarily lung cancer, and then other cancers, as we will see, and the rest of them. Included here also residential fires due to cigarettes and other causes. So serious it is. Let's come back closer to home, New York State. Numbers real for 2012, not too long ago, 4 years ago. Look at those two columns. Premature death due to tobacco use is over 26,000. Then, interestingly enough, poor diet and physical inactivity is close behind. Overweight, obesity, we know what that causes. And there are the others. So these are the leading causes of preventable premature death. Problem? Yes. So look at these two tables. The one on top shows you the incidence of cancers in the United States. Again, this is true for the year 2012. By the way, most of these statistics are from the CDC, Center for Disease Control, the National Cancer Institute, from Sears, from the Surgeon General's report. And in men, the upper bars are in men, the lower group is in women. In men, the most common cancer, prostate. In women, breast. But in both sexes, the second most common cancer is lung cancer. So, a serious problem. Now, not only is it common, but it's deadlier than all the other cancers. But it wasn't always like this. It really wasn't. How do I know? In my library are some older textbooks. I picked this one. 1925, Dr. Lilienthal, a thoracic surgeon at Mount Sinai, 2-volume book, very impressive. And when you look through this book from 1925, and you go into the section about neoplasms and tumors and growths, he states, primary pulmonary neoplasms are among the rarer thoracic diseases. It was rare. He quotes Ewing. Now, we all know the name Ewing from Ewing's sarcoma, a malignant tumor of the bone. I found out Ewing was a professor of pathology at Cornell and at the Young Memorial Hospital, and a very well-respected pathologist. And he's quoted in this textbook as saying as primary lung cancers are 1% of the total number of carcinomas in all parts of the body. It was a very rare cancer. And now all of a sudden, it's the second most common in each sex group. Now, this is a graph that really keeps haunting me. Look at the red line, concentrate on the red line. This graph shows rates of death from various cancers in the US population starting in 1930 and tracing it up to 2009, almost all of last century. And the red line is lung cancer. And look where it starts out in 1930, way down on the scale, along with others, pancreas, etc. And then it starts climbing, and it peaks, and fortunately starts dropping, and we'll get into that in a minute. So this is a new disease, which was rare before and became the deadliest of all malignancies very quickly. Smoking gun? No, we have a smoking cigarette. That is the answer as to why that is happening. And I'll show you a curve. And that curve is the consumption of cigarettes per capita in the United States, covering a similar period of time that cancer mortality graph covered. And when I put the two side by side, you could almost superimpose them. So if there is a cause for this steep rise in mortality from lung cancer, it's cigarettes. and that is really a 20th century plague. Now, the human race has known many plagues. Some of them have been eradicated: polio, smallpox. But there was a time when this is what a doctor looked like when they went to treat the plague. This is a middle-aged doctor, and that beak is not to scare away the devil, it's to contain all kinds of aromatic things to take away the stench that they otherwise would have had to inhale and go to take care of their the victims of whatever plague they were treating. But this tobacco is a 20th century modern plague that we brought on ourselves. So when did we find out this smoking was really what was causing the problem? A little bit of recent history. And again, coming back close to home, to Phelps. This is an opened up cover of Reader's Digest from January 1950. Now, when I tell people that I live in Pleasantville, they say, oh, Reader's Digest. Now, when Reader's Digest was published in 1950, there was no post office in Chappaqua. So the whole world thought that Reader's Digest comes from Pleasantville because that was their post office address. Anybody here know that? Look at the first, this is January 1950. Look at the first article. I'll open the book, I'll open it. Question: how harmful are cigarettes? And it's almost worthwhile reading the first chapter. In all the history of human habit, there have been few changes so remarkable as the tidal wave increase of cigarette smoking in the United States. Within a single generation, a new habit has laid hold upon an entire people to an extent which we do not begin to realize, and with effects which we certainly do not understand. Last year, 60 million Americans consumed 400 billion cigarettes every year. Some 800,000 non-smokers joined the smoking ranks. So there was this huge epidemic, I can't even use another word for it, of increasing smoking. And I remember growing up, sitting in my uncle's waiting room. He was a dentist in Tel Aviv, and he had American magazines. All you saw on every page were these full-page advertisements of cigarettes and smoking. And when you went to the movies, you saw these. And later on, when television came on, most of us who are old enough remember how widespread advertising for cigarette was. And it became a national habit. So, by the way, if you look at the bottom there, you see that if you wanted a reprint of this article, you could write to Pleasantville. Well, I'm going the wrong way. You see there to Pleasantville, New York, and you would have paid, I don't know, a few dollars for several hundred reprints. Things were cheap then. In this article were several important articles supporting the contention that cigarettes were harmful indeed. And this is a historic paper for several reasons. First, let's talk about the authors. Ernest Winder and Everts Graham. Dr. Winder was still a medical student in 1948 when he did an externship in New York at the Bellevue Hospital. And he was present at an autopsy of a patient who died of lung cancer. And it really impressed upon him when he talked, either before the patient died or afterwards, I'm not sure, to the patient's wife. And she told him what a heavy smoker her husband was. He was a real chain smoker. And he says, I am sure that it's the cigarettes that did it to him. So Dr. Winder finishes medical school, goes back to St. Louis, Missouri, Washington U. And there he starts collaborating with Everts Graham, who was the Chief of Thoracic Surgery in St. Louis. And they look at over 600, almost 700 cases of proven lung cancer, either surgically or by autopsy, and go back and look at the smoking history. 98% of those who had proven lung cancer were smokers. So all of a sudden there's this smoking gun. Now Everts Graham then gets, by the time he published it, he already had the reputation of having done the first successful pneumonectomy, removing an entire lung from a patient with lung cancer. He was a dentist from the local area who had lung cancer, went into the operating room with the plan of doing a lobectomy, and ended up having a pneumonectomy and survived. A little bit of personal history. This was not the first pneumonectomy ever done with survival. A year before that, my professor of surgery, Rudolf Nissen, while working at the Charité in Berlin, had done a pneumonectomy not for cancer, but for post-traumatic bronchiectasis in a young woman with survival. So Nissen gets the credit for the first pneumonectomy, but Graham gets the credit for the first pneumonectomy, successful pneumonectomy for lung cancer. Dr. Graham died in 1957 of lung cancer. He himself was a cigarette smoker. And when I think back of my training, 3 of the 4 cardiothoracic surgeons that I trained under were heavy cigarette smokers. This is the 60s. So it was ubiquitous. So we now knew that cigarette smoking was causing lung cancer, but that it was causing cardiovascular disease did not come out till a little bit later. After World War II, the Framingham study was initiated in Framingham, Massachusetts. From this study, we've learned a lot about hypertension, about cardiac disease, and the cardiologists in the audience know more about it than I do. But look at their first research milestone. The first one that they reached and published in 1960, cigarette smoking found to increase the risk of heart disease. Wow, okay. So here we are in the 60s, and we still are proving it. And then came the first report of the United States Surgeon General in 1964. Widely debated, widely publicized, and it had a good effect. A few quotes. Cigarette smoking is a cause of lung and laryngeal cancer in men. In men. It is a probable cause of lung cancer in women. They weren't ready yet. They didn't have the statistical backing to say that it was. It is the most important cause of chronic bronchitis and increases the risk of dying from chronic bronchitis. The term COPD was not coined yet. People were calling it chronic bronchitis. That COPD came later as a term. Cigarette smoking is associated with an increased risk of dying from pulmonary emphysema. So here, for the first time in 1964, we have an authoritative publication telling the world how harmful cigarettes are. There were 32 such reports between 64 and 2014, which is the most recent one. And each and every one of those addressed one or the other known health consequence of smoking, direct smoking and secondhand smoking. Here's the curve of mortality from COPD. And it's so unfortunate that in my own practice, I have seen more than one elderly patient whose lung cancer was cured with surgery, no recurrence, and they only go on to die from unrelenting, progressing COPD and its complications. For this, we don't have a cure yet. And what is interesting is that the risk of developing cancer and COPD in smokers is much higher today than it was in '64. Now, the cigarette that we smoke today is not the same cigarette that somebody smoked 40, 50, or 60 years ago. The industry has been changing the composition, the manufacturing process. We, for example, are wondering, why is it that the typical cancer of a smoker that we learned about in medical school was squamous cell carcinoma? It's rare today. Most of them now are adenocarcinoma. Why is there a change? Well, I don't think we'll ever know for sure, but it is my belief that it is probably a change in the cancerogenic materials that people are inhaling due to changes in the process of manufacturing the cigarettes, to which we're not privy. Big secret. So, just to summarize some of what the most recent Surgeon General report states, and all of it based on well-researched data. On the right-hand side, different chronic illnesses. On the left-hand side, different cancers. And look how long the list is. And in the most recent publication, for example, they have data to show that cigarette smoking increases the risk of developing diabetes. So there isn't anything pretty much that is not caused, anything that we treat that is not caused somehow or worsened by smoking. The bottom line is, most of us, if not all of us, would like to live as long as we can. And cigarette smoking takes away a good portion of that life. And it's women on the left, men on the right. The life expectancy of smokers is reduced by 11 to 12 years, of all causes. So again, to put it maybe more in closer perspective to everyday life, these are recent figures from 2013 in New York State. The blue bar is deaths from lung cancer in the United States of America, the whole country, but from lung cancer alone, not talking about all the other cancers and all the other health consequences. Almost 160,000 deaths from lung cancer in 2013. Compared to that in red, how many died from a motor vehicle accident? I'm sorry, how many died in, the red is a motor vehicle accident. Move over to the right, and down below you see much lower, much shorter bars, because the numbers are small, about the same ratio. Almost 9,000 people died of lung cancer in New York State and 1,200 from motor vehicle accident. The difference is, I don't think we're going back to horse and buggy, and we can make our cars safer, and we would accept a certain rate of accidents and deaths from the fact that we drive cars, but we don't have to accept all the deaths from tobacco, because we could live without smoking. So again, just to bring the point home of how serious the problem is, smoking is still very prevalent. 18% of adult Americans smoke, 42 million currently. But what bothers me more is the fact that 3.5 million school children smoke. And I live right next to Pleasantville High School, and I see those kids congregating after school, and they're lighting up. Every day, more than 3,000 young people, younger than 18, smoke their first cigarette. And I'm not even getting into the pharmacology of nicotine addiction, but the young brain is far more susceptible to developing addiction to nicotine than the adult brain. And the younger one is when they took their first cigarette, the more likely they are to become addicts lifelong. And the sad part is that of these 3.5 million middle and high school students that smoke, 5.6 million will die prematurely. So this whole thing is not just a matter of developing disease and living less, it's costing. What is the burden of tobacco smoking on our economy? It's mind-boggling. The estimated financial burden in the 3 years between 2009 and 12 recently is somewhere around $300 billion a year, of which that much is spent for direct medical cost, and 150 billion is from loss of productivity due to premature death. These bar graphs show the distribution of this cost among the states. On the left, the tallest column is California, and if you go to the right, the second tallest one is New York State. We're a little bit ahead of Texas and which is the other one? I can't read it. Florida. And each color represents the component of the cost. Hospital, outpatient medical care, drugs, etc. So how can we end it? I'll deal with it as if it were really a medical condition. Eliminate the contagion, okay? So we were able to eliminate smallpox. We're able to pretty much eliminate polio. We're fighting Zika, Ebola, okay? How do we fight this one? Well, if we could eliminate cigarettes or cigarette smoking, that would be great. Simple, right? But anybody who travels anywhere, outside this country especially, and you see the amount of smoking that goes on everywhere, I don't think this is going to happen, not in my lifetime. But if you can reduce it, that's already some benefit. So if we can't worry about the whole world, how about for us? How about reducing it in America, eliminating it in America? Now, unfortunately, there was this thing with prohibition of alcohol. I think they picked on the wrong thing. You know, I don't think ever was there such a rate of death and illness from alcohol as we know there is from tobacco. And with the failure of that, I think the likelihood of ever achieving a prohibition of smoking is remote. Locally, we can do a little bit more. So once people have smoked, and believe me, while quitting is good and quitting is important and quitting has its definite benefits, you cannot erase the damage done by years of smoking just by quitting. So we still have to be aware of that fact, and once we know that somebody has a history of significant smoking, we have to keep an eye on them. And we have to, number one, get those who smoke to quit, and then screen those who had a significant smoking history for any smoking-related illness. How to eliminate or reduce smoking? With regulation, and some of it is effective. Taxation, yes, and education primarily. Now, when the Surgeon General report came out, there was a very small print label on each cigarette package. The Surgeon General of the United States has determined that cigarette smoking may be harmful to your health. Remember that? So nobody read that, nobody believed it. So then they made the signs a little bit clearer. Smoking kills. It started in Europe, finally moved over here. Maybe it helps to prevent some people from picking up that pack of cigarettes. But I look at that other warning, the warning at the railroad crossing. And this one is right next to old headquarters of Reader's Digest in Chappaqua, okay? So nobody in their right mind would ignore that crossing. When that light starts blinking red, you're going to stop your car. And we know from local recent history that when some people don't, they end up paying a serious price, killing themselves and others. So what's the difference between this warning and that? This one will cause harm right away. The other one is years down the line, and everybody else around me is doing it. So I'll stop tomorrow, I'll stop next week. Part of the problem of the warning. However, there is a light at the end of the tunnel, and it's not a locomotive coming in the opposite direction. There are now more ex-smokers than active smokers, and more than 50% of ever smokers have quit. So again, let's come closer in now. Some information here at Phelps. If we're going to make a dent, we have to look around us and say, who is there that we need to target to educate, to screen, to help? First of all, our patients. Those that are on our floors, those that come and leave our emergency department, and those that we see as patients in our practices. And I put down PMA because that's where I got you some numbers from, Phelps Medical Associates. And then our staff. Now, you all know that we became smoke-free as a campus, and I'll mention that in a minute, and we still see members of our staff who, when it comes down for their lunch break, they either get into their car and drive off somewhere to smoke, or they go across the road to where you go down towards Kendall and they stand there and smoke. So these are people that can be helped. And I think we need to start some kind of a program to all of our associates, all Phelps employees. Let's start there. And then the community. I think it's important to try and get into the schools, to talk to kids. And here I have a thought, it's my own, I'm not sure if I'm right or wrong, that more important, if I were sitting here in front of a bunch of high school kids, more important than targeting the smokers, as we've traditionally done, don't smoke, it's bad for you, it's going to kill you, blah, 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 is talk to those who aren't smoking and tell them, make sure that your friend next to you knows how bad it is. Let's get peer pressure to work. Try and educate the non-smokers how important it is for them not to accept the fact that somebody else is smoking. Put the responsibility upon all the non-smokers as well. So, what are we doing already? Here are just two representative portions of charts. You know, when we admit a patient into the hospital, Meditech asks us to complete information about smoking. Some of it is marked with a red asterisk. It must be entered, not all of it. And I'd like to see all of it because it is important for us to be able to document for each individual who smokes what is their smoke exposure, pack here history. If they quit, how long ago was it that they quit? Down below is a printout from an ECW record, not from PMA, from an outside institution, but it's the same medical record. And you can see where I circled in red the smoking status. That has to be up front on every chart. Just like the BMI or the blood pressure, the smoking status has to be there on every visit. And when we look at it, we say, aha, well, what have we done about this lately? Mrs. Jones, are you still smoking? Have you done anything about, and so on and so forth. So if we don't recognize the smokers, we can't help them. So here's some numbers that I got out just last week from Meditech. Inpatient discharges in 2015, 8,079, the blue bar. I was very happy to see the green one. All these are never smokers, okay? That's almost half. And then the various shades of red are the smokers. The dark red, the solid red, are current smokers, everyday current smokers. And the stippled red are former smokers. Together they represent 37% of our Phelps discharge patients last year. That's not an insignificant number. These are the ones that I, as a thoracic surgeon, look at, aha, these people maybe need to be screened, not just for lung cancer, bladder cancer, laryngeal, and others. We'll get to that in a minute. So that's inpatient information. Emergency room discharges. And as I was reviewing these slides last night, I saw that Enrico Sabatelli, who put these numbers together for me, wrote TNR. Anybody know what that is? I don't know what TNR stands for after discharges.
Treated and released.
Oh, treated and released. Oh, okay. Oh, okay. So I don't believe these numbers. Only 18% a history of smoking from people who walked in and out of the ER. What that tells me is that somebody is not getting the information. Somebody is not recording the information. So we need to do better. Our ambulatory patient, PMA, Phelps Medical Associates, from ECW. 26,000 plus annual visits total, the top 3 bars in green. And you can see that there are more ex-smokers than current smokers, which is, encouraging. But still, when you add the two together, 64% have a history of smoking, either current or former. Again, a group that is at risk for developing health problems that we need to address. But look at the bottom cluster. That was interesting. Arbitrarily, I chose to look at male, female, older than 60, younger than 60. And females younger than 60 were the only group that had more active smokers than ex-smokers. So not only have they come a long way, baby, but they're still there. So what has happened here at Phelps to deal with this issue? In 2009, we opened the Thoracic Center. That's when I came over here from Montefiore, started dealing primarily with lung issues. And then in February of 2011, we became a tobacco-free campus. You all remember when that happened. And I think it has pushed some people to quit and certainly eliminated the risk of secondhand smoking in the workplace. I think it was very important, and we're not the only ones. Now, after the groundbreaking publication in the New England Journal of Medicine in 2011, November, of the results of the lung cancer screening study with CAT scans, showing that high-risk patients who are screened with CAT scans have about a 20% reduction in mortality compared to those that are only screened with a chest X-ray. We realized that we need to have a organized way of dealing with lung nodules. And we opened the Westchester Lung Nodule Center here at Phelps. Initially, there was a very robust advertisement campaign, resulted in many calls. Jeanette, who's sitting here, who manages my practice, has answered calls from as far as California, New Mexico, and people started coming with CAT scans in their little package, the disc, to get an opinion about how to deal with lung nodules, and it's still going on. We have a website which still results in many calls, I'd say weekly, we got at least a call about somebody who found out that they have a lung nodule and they want to have a consultation. But this was all to deal with lung nodules that were picked up incidentally due to examinations for other reasons. But we were very interested in starting a screening program, knowing that it would lead to discovery of lung cancer at an early stage when it is still curable. And our Department of Radiology not only was designated by the American College of Radiology as a diagnostic imaging center of excellence, but after going through a series of all kinds of bureaucratic requirements, we were designated as a lung cancer screening center. And it's important because this time it's not just you go in for a test. The data has to be recorded, the data has to be submitted to a central registry, the patients have to be followed, the patients have to be screened before they are screened with a CAT scan. We also joined the Lung Cancer Alliance and were approved as a screening center of excellence by the Lung Cancer Alliance of the United States. In 2015, in October, we screened our first patient. It's been slow. Referrals are coming from members of our own physicians community, but we are hoping to have an impact. I tried to bring this out to the community. We had a lecture scheduled in October right here in this auditorium. 3 people signed up. We had to cancel it. So we need to spread the word better. So one of the things we're doing, and the doctors among you expect to get this in the mail, and please don't put it into the round file when you get it. This is a letter that we're mailing out to 425 physicians, which detail the lung cancer screening with low-dose CT. Questionnaires are attached, as you can see. And the bottom line is 366-2333. You have a patient who you think meets the requirements. You don't have to bother with the requirements of a shared decision discussion, etc., that is outlined in this mailing. You can call us. We'll be happy to take it over from there. At the same time, a mailing is going out to patients that we identify as smokers from our discharge, from our admission H&P. And they're going to get a letter not saying, hey, because you smoke, you better. You know, it's really worded in a very friendly way, informing them of the help that's available, informing them of the importance of doing what they can to stop smoking. You know, Arthur said, what's a thoracic surgeon doing with the smoking all of a sudden? And I realized that I really wasn't fully equipped to deal with this issue of tobacco and smoking. So on the way back from a meeting of the Lung Cancer Alliance in Washington last October, I got off in Philly and I spent 5 days in Philadelphia and took a 5-day-long course sponsored by the University of Pennsylvania, learning about the problem of tobacco addiction and learning a few tricks of how to become a tobacco treatment physician. I then joined the organization, the Association of the Treatment of Tobacco, and believe that I'm better equipped to help patients who want to stop than I was before taking this course. Still green at it, I'll admit. Now, here are the last couple of outlines of what I think we have to do. Quitting, never smoking, the most important. But there are people around us who have potentially life-threatening conditions that they don't know about yet. And the only way we're going to find those out is with screening. And here's a list of all the various cancers that we know are at increased risk due to smoking. And a list of the specialties that deal with them and the tests that are required to screen. And I think this is, again, something that we need to do in an organized, systematic fashion with, the medical record identifying whether or not patients had undergone screening for different conditions. And in the end, I think what we're going to do is we're going to save lives. Now, you saw that the most important cause of premature death from smoking was cardiovascular. It was not even cancer. So here are the lists of medical conditions, not cancers, that we need to screen for and how. And it's long, but important. The one thing that really sunk in as I reviewed this topic and have been thinking about it and prepared this presentation, this tobacco is a stealth killer. It is really, it's there, it's all around. Now, I could be an infectious disease person talking to you about Ebola. So how many of you are ever going to see a case of Ebola? But you show me one hand up here of somebody who has not firsthand dealt with another person who had some problem due to smoking. It's all around us. So we have to, first of all, ask every patient we see about their smoking status. I had physical therapy here a few months ago. Every time I went to that window to register, they asked me if I've been to West Africa. Okay? Give me a break. But the same thing, I think, what they should ask, are you a smoker? Does anybody in your family or in your household smoke? Would you like to have help quitting? And again, along the same line as I said about the school children, I think we can gain much more traction if we get people around a smoker to get them to quit than, concentrate all of our efforts on the smoker themselves. So the name of the doctor who treated the epidemic was Dr. Schnabel. And I'm not going to wear that mask, but if you have any questions for me, we've gotten to that point. Yes, Michael.
There's a really beautiful old movie called Now Voyager. Betty Davis and Paul Heinrich are falling in love. And back then, they didn't show people in bed or disrobed. So the metaphor for their relationship were a couple scenes where Paul Heinrich lights 2 unfiltered cigarettes. He hands one to Betty, and they smoke together, expressing their love for one another, achingly romantic. But when you look at it now, you see them exhaling smoke onto each other. My point is, there's a real culture change, and I think that we as educators can take advantage of that. You alluded to it. There aren't many people who get to their 20s who smoke, continue to smoke, who haven't started smoking before then. So I think the key is educating young people and teenagers. There's a program that the American Academy of Family Physicians has. I think they still have a Tar Wars. Does that still exist? There's a lot of support for physicians to go into schools and talk about this. And I think if we don't already do it within family medicine and the residency, maybe it's something we could pursue. That's my question.
The addictive power of nicotine seems to be extremely potent. In other words, I think I've seen people quit heroin easier than getting off.
It is more addictive than heroin.
You have very intelligent people who know all the dangers and still cannot force themselves to quit. Now, I find that I've had some success with a combination of hypnosis and perhaps some of the pharmacological agents that can be used to blunt the craving for nicotine. But even with that, I think the overall statistics are not that good to get people to quit. I think once you're heavily addicted, the interventions are not that effective. It might be something like 20 or 30% at best, something of that nature.
You know, there could be so many sub-talks to this one. This is really was the big picture. This is from 10,000 feet, coming down a little bit right with a drone right over Phelps. But the whole issue of the addiction, the whole issue of how to treat it, the issue of nicotine supplements, the whole new emerging issue of the electronic cigarette, okay, the vaporizers. This is something that is enough to keep somebody busy, 24 hours a day, and if that's not enough, there's still the night. And it's really a challenge, but I think if we are to start making progress, it is, number one, identifying the smokers, two, offering them whatever help we can to quit or cut back, and then screen them for early detection of the problems that I listed. And that's our obligation. It's our obligation. And I don't want to, open up this door, but maybe I will a crack. I can foresee 5 years from now, somebody with a stage 3 or 4 lung cancer who finds a lawyer who sues that person's primary care physician because 5 years earlier, this person met the criteria for low-dose CT screening and was not referred for one. And you stand there, in front of the jury, and you're asked, doctor, why did not you order that screen when it could have found this cancer before it spread? So, even that's going to come.
Bobby, it's important to point out, because a lot of patients don't want to pay for these screening tests, that CMS now pays for a lot of these screening tests. For example, abdominal aortic aneurysm screening for hypertensives who smoke, who are 65 and over, I believe, and same for low-dose CAT scanning for lung nodules if
Right.
you can document the smoking history. So, if someone has these criteria, it's okay to put down screening for
Absolutely.
as long as they meet those criteria, and CMS will pay for it.
Absolutely. I mean, that was really one of the reasons in delaying our first screen. We wanted to be sure that everybody is covered. And it took CMS a nice long time, 4 years, with all the data right there in front of them till they finally approved. And with that, most of the other commercial insurance companies fell in line and are paying for screening.
What is the criteria of a former smoker with regard to screening? How far back?
So the age has to be 55 to 79. Their history of smoking has to be of 30 pack years, and if they had quit, they will have to have quit less than 15 years ago. So I mean, if somebody quit 20 years ago, doesn't meet the criteria. But now, there are other risk factors that are added on that increase the level of suspicion and will have, as an impact, inclusion into the screening. For example, A very important risk factor is a history of lung cancer in a first-degree relative, brother, sister, father, mother. That's a big red flag. And then additional exposure to asbestos or radon. And the truth is that while those criteria are ones that were put forward by the insurance companies and CMS, once a patient with a history of significant smoking sits in front of me, and I think that that person should have a CAT scan, I find a ways of getting it. You know, we may not enroll him in the formal LDCT screening program, but we can still do the right thing.